You're listening to a speech therapy PD podcast. Earn 0.1 ASHA CEUs for this episode by completing the accompanying course online at speechtherapypd.com.
All right, folks, we are back. So y'all know that I love looking at the ASHA SIGs, and I love putting an emphasis on the podcast for expediting research to practice, because not all of us have time to sit down and look at the SIG articles. What's even cooler is that SIG waived the fees as of January 1st. So now you can access all of these perspectives for free. So you can go right to the source. But over the summer, I was reading an article by Dr. Kelly Kleinhans. Yes, who I knew from CSAP. We were CSAP presidents back when I was with South Carolina, and she's with Tennessee. And
I was in Kentucky at the time.
You were in Kentucky then?
I was working in Kentucky. I have always lived in Tennessee, but we are a border state, and so my job was in Kentucky. So I was the Kentucky Speech and Hearing Association president.
I got nothing. I was in South Carolina and now I'm in Virginia. So but this is courtesy of the Mr. Dawson's job to make things blow up or not blow up. And now we make things not blow up. And this is really important. And when it's a bad day, it's a bad day. But she and Courtney, who works with her, wrote this lovely article. And it was featured in Perspectives. And it was all about how do we use mind maps, which is something I still don't fully understand, to help students learn in their clinical practicums. And they use this word, in full disclosure, I've worked in 3 universities and I still don't know what this word means. Pedagogical, don't even know how to say the word, but I teach people to swallow. So they were gracious enough to come on and for Dr. Kelly again to come on and talk about this article and their research and how we can inspire and grow our future so that more of the humans we've been called to serve can be served. And at the end of the day, that's what it's all about. So, Dr. Kelly, I'll start with you. Hi, welcome. You came on years ago, so we'll have to tag that in the show notes. But what made you want to be a speech therapist, and how did you get here today?
That's a funny question, since I'm probably at the tail end of my career.
That's
think that's why I did it. 100 years ago, I became a speech therapist. I think, to full disclosure, at this point in my life, because I didn't like math, and I thought we didn't have to do math. One of those kids. But that's a lie. That's a myth. I'm going to bust that myth. We use a lot of math, and especially when I did my doctorate work and you had to take 1,000 stats class. So anybody thinking you should come into this field for that reason is probably not the best reason. But seriously, most people, when we read the admissions applications, I was touched by someone who couldn't communicate, and I like people, and I like to see people be able to reclaim their social roles in life. And so just wanted to be in a helping profession back in the day. Remember, I started before there was internet and things like that. So I really got into speech-language pathology, not really, really knowing what it was, other than having watched a little articulation session of a friend of my mom's many, many years ago.
That's beautiful.
Mm-hmm. Oh. And I do want to say, Michelle, we did meet through CSAP, and I was just telling Courtney that when I saw your email again reaching out, I got so excited because I said, this is one of the nicest people I have met in our profession outside of our inner circles where we really get to know people. So kudos to you. And I'm so proud of the success you have with your podcast.
Thank you. Oh, that's all Jesus and a whole lot of the folks behind the scenes making this look good. And to be honest, a fair bit of red wine on a Friday night. There's that. But que sera. But thank you. Courtney, hi. Nice to meet you.
Hi. Nice to meet you. I'm really, really excited to be here. A little bit starstruck, I'm being honest. But I became a speech pathologist back when I was still an undergrad. I was an aide in a special needs classroom. So I got to see when kids were being pulled for services. And I always knew I really wanted to work with children. And then I was lucky enough in my student placement, I actually was placed with the supervisor who was doing feeding. And at the time I was like, what is this aspect of our field that really wasn't covered a lot in undergrad and grad school. And it kind of started me on that journey. I loved it from the start. And I knew as soon as I started practicing, I went right into a focus of feeding. And I've been able to build the program where I am. And then I was lucky enough to meet Kelly, and she saw the potential in me and pulled me in so that I could help teach the students at Austin Peay that are going out into the world now. So I'm just very, very happy and lucky to be here.
Yes. Well, the world needs more feeding therapists and it's so hard to teach this because so few grad schools have clinicians or an on-site clinical that actually offers this. And so many programs, their dysphagia class squeezes PFD in, but then it's squeezed in by a professor that does research or practice clinically with adults. And those are, two very different worlds. And so I love it when I see programs embracing more PFD because these babies, the babies are saving. We weren't saving 5 years ago. And the old saying that feeding wasn't in the schools, this is no longer the case. So even our school-based clinicians are having to embrace this. So, okay. Well, let's take it from the top then, ladies. We have a beautiful set of questions, but can we start with the pressing one? One, how do you say that word? And two, what does it mean?
I always say pedagogy, but it doesn't mean I'm the authority on it. So you can choose to follow me, or we could Google it. I don't know. But
if you change the pedagogy, is it pedagogical? I
think it's like dysphagia. I think it's where you were trained and who you were trained under, and you pick up their version.
We'll go with pedagogy, then that works.
Well, I told you I'm too old to change. So. I think it's important. So it's simply just the study of how we learn, and it's been in and of itself, it's been a blossoming field in terms of how we are much. As SLPs are in higher ed, we're looking at it now, recognizing the cognitive psychology behind how we learn, how the brain is behind learning. And so it really tries to structure or break down what are the most effective and efficient ways that we teach learners. And so having been a speech-language pathologist for 100 years, and I've always worked in regional comprehensive universities, so I haven't had the luxury since I've been in higher ed to specialize like I used to, because you have to kind of know a little bit of everything. I kind of shifted my emphasis with research to looking at how to be a better teacher in higher education. And so most of my recent publications and presentations have to do with teaching. And in particular, I think what we want to do is most of what we do are complex cases. And if we look at it from the student's perspective, every single one of them is a complex case.
Yes.
From not knowing how to play with young children to conducting a formal and informal assessment of an adult neurogenic case. So they have no background experience in the clinical world. So to me, they're all complex cases. And the question becomes, how then do we help students take this massive amount of information, organize it, and weed out what's important at this point in time, but still hang on to things that might become relevant later on, synthesize that information, and then help it become an actionable item in clinical decision making. I mean, that's really what it's about. How do we take the massive amount of information that students have to learn across the 9 service delivery areas in just 2 short years to be competent clinicians, and to do that with entry-level confidence that they can protect themselves and their license?
Yes. And it's incredibly important that external clinical supervisors learn how to teach, right? So we get them as, I remember my first speech babies that I got, I've always called them speech babies. But I remember my first speech babies as external clinical supervisors, and young Michelle couldn't understand how come they didn't know these things when they were in their practicum with me. I couldn't wrap my head around, why don't they, this seems so basic. They should have learned this in their clinical practicum on campus or da-da-da. And the older I got, the more I realized that's not a fair assessment, because they're there with me to learn these things. And I couldn't grasp just what you said. There's so much that these students have to learn a little bit about a lot for those 9 areas in 2 years. But you're looking at it through the lens of, but I've been doing this for even 2 or 3 years. You know so much. And so, folks, when you get your new speech baby, you need to take it away that like they're there for you to teach them. So that's why we have to read these research articles. That's why we have to reach back out to the universities so that we're learning best practice on how they learn, right? It's like this beautiful little circle that goes back and forth. Okay, so Courtney, how'd you get pulled into this mix?
Well, so when I met Kelly at the time, I work at a private clinic. We do outpatient, and I'm the lead feeding therapist there. So I oversee the feeding program across their different locations. And I had already started developing some competencies just because feeding is so complex.
Yes.
You can't just walk in and start treating it right away. So we were building like a mentorship program for therapists that were interested in doing feeding, to give them that support, but not have them just jump right into where you're getting a complex case. And the program at Austin Peay, they were just going through starting the grad program for the first year. And so Kelly and I met, and she, I guess, saw the potential in me and was like, pulled me right in and said, do you want to teach a pediatric feeding and swallowing course? And
Yes.
At first I was like, are you sure you want me to teach it? But she's been such a wonderful mentor, and I'm very lucky and excited. This is my, I think, 3rd year teaching, and I've loved it every year. So, and that was kind of the inspiration behind the article, was when we were working together, and yeah.
That's amazing. Dr. Grace Howe out of North Carolina State University, in North Carolina Central University, NCCU. She was the first to give me the opportunity to teach the PFD class, which when you don't have a PhD, or teach the graduate course, but when you don't have a PhD, it's hard to break in. Like, you can be subject matter expert, but certain universities, like, there's just requirements. And it was just, so Grace, thank you.
Yeah.
Okay. Well, within the framework of the article, y'all talked about mind maps. So can you kind of take us through what a mind map is in case-based learning, and how y'all integrated this within classroom and then into the article?
Yeah. Do you mind if I just tell you a small little backstory about how this came to fruition? Because
Yes,
it is
please.
very much Courtney's story, so to speak. I have done the pediatric feeding 100 years ago, like back early in my career. And when she and I met, it was so refreshing to hear her talk about stuff and to find out what was new on the topic area and what was still we're struggling with, the same old stuff. Courtney just had a wisdom about it and a very thoughtful, mindful approach about it. And I just really, really valued that. And when I started the program at Austin Peay, it was, and this was 5 years now, but it was my desire to move to a competency-based education, like Courtney said. Yeah. So it was for us, for our program, developing our pediatric feeding competencies was one of the first ones that we've done. And Courtney was instrumental in that. And I said, you've got some really good knowledge. You need to present. You need to present, and then you need to get a PhD, and then you can come work for me. So of course, I pressured her a little too much, but we did get her to the state presentation. So she presented a TASP a couple years back, and she is very much into interprofessional practice, which I'll let her speak to. And so she presented with her team member, her occupational therapist, and did a wonderful case study on these two twins that you read about in the article, but they're kind of in the background in this article.
There was a really beautiful attachment that went through and described it, but you have to go to the attachment. So sorry, just wanted to
the supplemental materials. Correct. Yeah. So when I sat through her presentation as a supportive mentor, I was like, this case is phenomenal. It has everything that makes a really great study. And one of the first pieces about it that was fundamental about that case study was you had twins that had that same in utero background, but yet presented with very different problems. So it was perfect to set up for generalization, which is what we want students to do. When you teach students problem solving, you want them to be able to generalize that today, tomorrow, the next 5 years down the line, but all the other cases they see. So I, at the time, was going up for promotion, a full professor, and needed one more publication. So I came to Courtney and I said, we need to write this up. Can I piggyback on your state presentation and tricked her into this terrifying, horrible ordeal of writing an article for 2 years. And we had originally submitted as the case study in and of itself because we thought there were so many things in it to learn. Because of the twin situation. But it ended up as as you often do as a writer and author, you get feedback and it keeps changing and changing. So the focus did shift to how do we teach this into the mind map. So full disclosure, this is Courtney's baby. I just covered it up in educational.
No, I mind. Yes. But the case study, wait, Courtney, can you describe the twin case study, like high level overview before we go into the mind map? That way the authors know about these sweet, precious babies. Also, I didn't extrapolate. Was how involved was the second partner in the care?
So in this case, it was a set of twins. They were born premature at 34 weeks. We saw them with their adjusted age. It was actually -3 days from their official birth date. They presented they were having feeding difficulties and a lot of sensory regulation issues. So at the practice that I work at, we created this infant feeding program where we used an interdisciplinary approach. So we have an occupational therapist and a feeding or speech therapist there from evaluation to give the family as much as they can at that first evaluation of, what are the underlying issues? How can we support looking at these different perspectives, because there's so much in feeding that is a whole body or holistic experience. Yes. So from the start, the occupational therapist is there. Allison, she is our third author that contributed to the article. She was there from the start, and she's a fabulous OT, does amazing with body work, infant massage, all of those specialties. But so for the case, 34 weeks, premature twins came in, difficulty feeding at the breast and bottle, but they presented just so differently. We had one that was very lethargic, could not stay awake for feeds, was not able to stay awake to sustain a full feeding. And then we had the other one that we were almost hyper reactive, where just any like startle, anything would completely dysregulate our sensory system. And we would get so upset that we could not feed, could not re-regulate to get back to the feeding. And so we would just almost shut down. So there was so much that was both feeding and that bodywork aspect, or that sensory regulation aspect. But for having, again, that same maternal background, they were such different cases. So when we did transition to, how can we use this as a teaching tool, you have the first case that you're able to do with the class together as you're walking through it and working through and saying, okay, let's see, what type of referrals are we going to need? What's our thought process going to be when a case like this comes in? And then you have your second twin where we're presenting completely different. We have a lot of the same information, but you have to change your clinical thinking because what we're presenting with is different than the one you work through together. So it ended up being kind of the perfect one, because you could work through one as a class, and then you could say, okay, now take this and I want you to do it independently, and let's see where your thought process goes, or how you change, how can we make this a dynamic learning, because each case that walks in that we treat is going to be very different. So this ended up being a very interesting one to present on, but then also to take and change to use as a teaching tool.
What I love is right out the gate, you're setting the framework that you cannot be a silo practitioner. Interprofessional education for interprofessional practice. This is the mistakes I would have not made clinically had this been a intentional concept 20 some years ago. But, gray-haired Botox I'm due in 2 weeks, but like here we are. Like it wasn't a drive like it was 20 years ago. And that's okay. Give grace for perpetual life. I mean, the profession's been around officially for 100 years and 6 months. So it's going to evolve over the last quarter century. But yes. Okay. So within that framework of the two very distinctly different cases that are intimately connected, how does the mind map work?
So if you can recall back when you went to school, whether you're thinking of your classroom sitting in the seat, or even when one of the novice mistakes of clinical educators when they first get their first student is they feel compelled to tell them every single thing they know on day one. So
I've done that.
One of those experiential mistakes. But the thing is, students are often faced with massive amounts of information, like just bombarded with it. And I would even say in the last 3 years, with the advent of AI and Google permeating everything we do, I mean, it just massive amounts of information. And our students have this cognitive overload. And they don't have a strategy to organize and synthesize and analyze this massive amount of information. So the mind map is a tool that's a visual representation of all of that information, that it forces the student to really focus in on the key concepts and really focus on a concept or construct knowledge about a concept more so than memorizing tons and tons and tons of facts. So as a visual tool, it's simply a radial diagram, and it's radial. It's different. A mind map is different from a concept map. Usually there's some type of hierarchy or specified organization in a concept map. But in a mind map, the mind map is more associated with how you draw these concepts together. How do you make these disparate pieces of information relate to one another?
Yes.
And so there's a lot of individuality in your construction of a mind map. If the three of us sat down today with a brand new case, none of our mind maps are going to look identical. Will we have overlap? Yeah, if we have some basic understanding of pediatric feeding disorders. For example, our mind maps would differ in that Courtney, I'm going to butcher this, Courtney. What is it? The AFRID? Is it AFRID or
ARFID?
So like, I wouldn't have that on mind map, but look, you both jumped right in like, oh, I know that. So it would be on your mind map to organize that information, but it wouldn't be on mine because I don't have that background knowledge. And that's the key thing about mind maps paired with case-based learning from a pedagogical framework is that we want students to start where they are. What is the knowledge that you have? And then I'm going to allow you or want you to experience something. I'm going to immerse you in some type of simulated or authentic experience. And then you're going to have new information that you're going to be the architect of your learning. And you're going to learn new information by taking what you know, what you just experienced. I, as the teacher or clinical supervisor off campus, am going to facilitate your reflecting on what did you know? What do you know now? How can we tie these things together? And how does that make sense? How did I think about that? What was my problem solving? What were the hypotheses that I accepted? What were those I rejected? What was information that was important before that's not important now? And so what the mind map does is it uses colors, it uses pictures, it uses a little bit of text, very different from taking notes where you have massive amounts of text, to just these keywords. And you organize this mind map around a central concept. So in the article, I think we used one of the babies, Courtney, for one of the mind maps. And then one of the other experiences, we just used the topic of pediatric feeding disorder as the central concept. And then from that central concept, you draw lines to other shapes that represent the other aspects or concepts, key points of the case. So, Michelle, you said you just really value interprofessional practices. So you might have a really large circle for interprofessional practices and have lots of sub circles that lead off, that branch from that in a really, really nice way that reflect your understanding of interprofessional practice. So your interprofessional practice branches would be so large compared to our students who have just an OT, right? The OT.
OT was fine motor and handwriting. And you're like, oh, it's a little more than that, a little bit more.
Or how about the physician? How about the mom? How about our other peers? So the mind maps really do take complex information and they give you a visual tool to work with those concepts. So instead of just memorizing, which the mind maps and note taking, they're equivalent as far as the evidence is for recalling information. But the mind maps are the piece that actually links that clinical decision making, kind of activates the clinical decision making, unlike note taking in terms of what the studies tell us.
So 2 thoughts. One, I never said the title of the article because we just jumped right in and geeked out. It is called Bridging Pedagogy and Practice, Case-Based Learning and Mind Maps from SIG 10 Clinical Focus, June 10th, 2025. It was volume 10, number 3, just so that everybody's got it handy. And the second follow-up thought is, do you have an example that's HIPAA compliant of a mind map that for this case that we could pull in as like a show notes to like add in afterwards? Would that be okay?
Yeah, I think we have the visuals that we created that we could share. Definitely.
Yes, that would be lovely. And so, folks, what I'll do is we'll add a link somewhere in the show notes. Okay, so then how do you take these mind maps and use them in class? And also now I'm kind of like, I might need to incorporate this to my next round of PFD teaching, because just like you were describing, Kelly, like I've got all of this focus on the interprofessional practice partners. Like I see a child with a rash and start thinking eczema, psoriasis connected over to a food allergy. Do we need dermatology? Do we need allergy? Like what else is going on? And my brain rapid fires there. And because I am neurospicy, I will word vomit at the students and not necessarily rein it in. But if it's color-coded, color coding systems work very well for me. But how do you do this?
I was just going to circle back to the case-based learning. I feel like that is such an important piece of with a PFD, just because there is so much that is involved in that diagnosis. We have, a lot of times all of the domains that it can entail. We have our medical, nutritional, feeding skills, psychosocial. And so first getting students to understand those and be able to identify those is our first challenge. But then also saying, what are the red flags that we can look for that are going to indicate, we need to do more. We need to refer more. We need to do more of an investigation, dive a little bit more into the case. Coming from a more clinical background, when I was structuring the course, that the clinical side came into it so much. So anytime I'm teaching a topic, a GI topic, I'm going to pull those cases and say, okay, here's a child, here's how they might present if we're more of a GI heavy case. How do we diagnose a PFD? Can you identify the domains that it's going to be? And then can we use something like a mind map for our thought process on where we need to go with a case like this? Because a lot of times, even just having the information is challenging for students. But if we can get them thinking in these different, more dynamic ways when they're in the field, they might not necessarily know right away of, hey, here are some signs that it could be like an EOE. But they can say, this is a red flag for like a GI. How can I work through this to think, what are our next steps with this child? So usually like week one, I'll bring up the consensus framework. We go through that together. I love a good visual. So I give all the visuals of, here are some cases, here are domains we're looking for, what falls into these domains, how do we diagnose it? And then as we're going through the semester and going through each of the different more specialized topics within a PFD, then we'll kind of relate it back to, can we diagnose a PFD? Can we see some of those red flags? And then where do we go from there? How can this build our clinical reasoning when we're still not necessarily practicing yet and seeing those in the field? So I feel like that case-based learning aspect is just such a great way to take some of these topics and give them application for the students to dive a little bit more into.
But that example is doable for an external clinical supervisor, even if the student has never had the PFD class, because again, the bulk of the students don't have a specific PFD class, or it might be an elective, which could be cost prohibitive, give or take FAFSA and their financial aid, right? But that doesn't mean that that's not something the student doesn't want to pursue. But I'm thinking in private practice, like I could pull 2 or 3 case studies and systematically go through with the student, hey, let's break down which of the 4 domains you're seeing. And if I was the SLP in the schools that just started picking up PFD, like, okay, these are the 4 domains, take it another step farther. And how does this impact education? Because I feel like if there's that immediate overlay, that it blends beautifully. I just finished reading Gut. Have y'all read Gut yet? Mm-mm. Oh my gosh, it's phenomenal. I have a picture. I'll send you. It's called Gut. And it's by this German GI/internal medicine doctor. And she's talking like the last couple chapters, like giveaway, folks. Here's your spoiler alert. It's talking all about depression, anxiety, and how much the gut is the second brain. But the way she describes it laying over the real brain, that's what it made me think of when I was talking about tying the case-based in, and then how it overlaps being educationally relevant. It looks, it's like that second brain. Your eating drives your learning. And yeah. Big picture connections. Yes. You have to read Gut. You will love it. Your eating heart will just love Gut. And I just started Everything is Tuberculosis, and now I'm assuming we're all going to die, but like maybe don't. Okay. So there's so much that we can cover. Where do you want to go next? So how do you tie all of this mind map into IPP? Tell me what you would like to tell me.
I want to say one thing. I think one of the really great things about a mind map is, and especially like Courtney said, if you really fold over the case study and have the mind map a case study, whether you're in the classroom or you're at a clinical practicum site somewhere, the student or the learner has the opportunity and is forced to make a clinical choice in a very low stakes environment. So, a lot of our current learners just get paralyzed with decision fear and anxiety over being wrong.
Yeah.
Like, oh, if I'm wrong, what will my clinical supervisor think of me? They'll think I don't know anything. Well, we know you don't know anything yet. It's okay. And they don't have that. They are not okay with that. We all are, but they are not. So the two things I would say is I tell my supervisors all the time, like they get sick of me saying it, but if they're complaining about something of a student, like, oh my God, they didn't know whatever, I'll say, was it a goal? Did you two sit down and establish this was the learning goal for the session? So like when Courtney and I did her pediatric feeding competencies, it was very easy for Courtney to say, Kelly, you wanted me to teach them how to prepare a food tray. But before they can prepare a food tray, they need this competency. So, she was able to pull exactly what her goals were when she saw a goal was missing. She was able to adapt her teaching in the clinical environment, having had that conceptualization of, oh, I need to be goal driven with my teaching. And then if you do it that way, then when you do the debriefs with your students after sessions, you tie it back to that goal, then they are cementing that knowledge that you're teaching on. They're chunking it in ways that are manageable. So now if you add something like, hey, you don't get to participate in this pediatric feeding session because I'm going to do a lot of hands-on stuff. So I'm going to have you just observe this one. And I want you, while you're watching, I want you to develop your mind map of everything you see that reflects our core foundation knowledge about how do we work with these types of babies. And then afterwards, during the debrief, you can take whatever your objective was for your learning and you could map it. You could look at what the student has prepared for the map, identify what they got that was accurate, spot on, ask why they put something somewhere or left something off, and then facilitate, again, make that link to what you want them to learn, and then have them make a choice. Like, well, what would you do differently? What do you think our next step will be? And there's no consequence for them. And if you learn the practice of not responding immediately with a yes or no, you're right or you're wrong, and kind of like, tell me more. What if you think about this circle? What about this part of the mind map? Students, they become the ones with the verbal diarrhea. They're going to be much more willing to take a chance to talk to you versus they're stuck in that something's right, something's wrong. And the three of us, just from years of experience, know there's very few certainties in any of the clinical practice that we get to do. So you'll expose them to the uncertainties of what we do, but how to make a really good informed clinical decision. So the mind maps can be easily used in offsite placements.
I love your enthusiasm, genuine, heartfelt passion for how you're teaching the clinical skills. Like that is, my soul needed that more than I can tell you, because I can share that not all program chairs have that passion for the bridge there. So thank you for modeling that. And also my immediate thought is, damn, I wish I'd had this, because I'm so quick at like pulling the students in. Okay, now watch what I'm doing. And I just expect them to take notes, but like, that's not structured. And especially for our other, our future colleagues that have executive function differences, because I'm hard pressed to think of disorders, because that means I am disordered and there's too much bias in that word. That helps. Having a tool like that helps. And we also have to acknowledge that our generation of students now, we have more neurospicy colleagues that are being honest about that. That's how we describe it.
I love that word.
Neurospicy. Well, I mean, my husband and the oldest have a touch of the autism, and bless them, Bear and Mommy have the ADHD. So like, there's trains and a lot of colors in our house. A lot. But for those that I have worked with that don't know how to interface with neurospicy students or colleagues, having a tool that can help scaffold that could also prevent communication breakdowns between the clinical supervisor and the student. It can also help a neurodivergent brain speak with a neurotypical brain. And there's so much research that those brains don't always speak the same language. And that's a huge professional challenge and a huge learning challenge. So yeah, I see you nodding passionately on this one, Courtney. Yes.
Yeah, I was going to say, I feel like with the mind maps, because you have a general structure, but your branches, they come from each individual student. So it gives them a visual that they, like, if your brain works one way or another, your mind map is going to look different, but you can still show your thought process and still make those connections. And even if they're ones that maybe we wouldn't jump to, us as, teachers or supervisors, you can talk through, you can say, well, tell me, why did you make this jump? What made you think this? Oh, I understand where you were coming from. Let's maybe circle back to here. Let's see, can we branch off that even more and say, let's take it a step further. So, for students who have just so much information, I feel like it is a way to give them that clinical reasoning. One of the big things that I really want students to walk away from in my class is, can you identify a PFD? Can you diagnose it and justify it? Can you show me how you justify it? And then same with if we're making referral recommendations, we need to know the red flags, we need to know, and I want them to be confident in that. And I feel like through this case-based learning or giving them these examples with these visuals or this thought process, we can get to that point of, okay, well, this is a PFD, here's why. And they can identify that information, and at the very least, treatment is a whole other ballgame that we do cover, but is a little bit more challenging. But at a bare minimum, when we're done with this class, are we confident in making these diagnoses and being able to justify it with our clinical reasoning? So, I feel like the mind maps and those visuals are such a great tool for that.
But your statement that treatment is so varied, but it's the eval. It's so Dr. Amy Delaney at Marquette University, she has Marquette Peds Neurodevelopmental Feeding Lab, and Amy's doing really cool research on typical mastication patterns, but from a texture perspective. It's Kelly, it's really cool. Look at me stimming over here, but it's just groundbreaking because her research shows that there are developmental texture patterns that are a little more user-friendly than the IDSI triangles. And embedded within that, there's developmental patterns for children with congenital heart defect. They're starting to extrapolate the data for little ones with Down syndrome. And then her next goal is to pull in developmental texture patterns for autistic toddlers. So that a way, from our evals, we can say, we see this characteristic, you are right on, indicates therapy, or we are delayed even for this anticipated etiology, so jump into therapy. But she's so quick to say, treatment looks sexy, but you have to do the eval.
Yep.
And that's the hardest part, because that eval dictates what your treatment is.
Courtney can elaborate on this, but when we first started the article after the presentation, our first drafts were so focused on a holistic approach to assessment. And how do you organize that information? And maybe that was God's way of saying this needs to be an article about teaching pediatric feeding disorders more so than an article about the cases, because we spent considerable time coming up with a model to say, how do we tease out these different pieces that are so married? We need to be able to address them in the article separately, right, Courtney? But yet they're so married. And so a lot of times our conversations were pretty challenging and robust, I should say, because we were like, where does it go? Does it go here? Does it go there? And it was a lot of fun to talk shop like that. But you're right, Michelle, that that holistic approach in assessment is the critical piece to anything that comes after that. 100% we agree. Right, Courtney?
Yes. Yeah. And I feel like, especially for students, when they're first starting out, they're so focused on just getting the information that taking it the next step to interpret it is so challenging. And a lot of times, especially in a clinical setting, you're expected to take all of the information, give your recommendation before you even have the time to write that up. So again, like the tools of like a mind map, it just gives them a thought process of, okay, I have all of this information. How can I break it down so it seems more manageable? And so I can figure out those next steps. Do I see anything, within that indicates warrants referral, warrants diving into one of these domains a little bit more. I'm lucky, and a lot of times I'm doing something and not realizing it. And then Kelly comes in and she's like, oh, you're scaffolding or you're using case-based learning. Like, let's talk about that. And so she's the person that's been able to really identify that and say, you're using this as a teaching tool. Here's why it's a great teaching tool. And then building on that. And she's been able to just help me become a better teacher and a better supervisor for the students that I get to work with.
Yes, because those things, we can be a great feeding therapist, but that does not necessarily mean that you're great at teaching it. Or you could be great at teaching something and a terrible therapist. And most days I'm hoping I land somewhere in the middle. And like, that's what if I land in the middle, but they walk away with a smile on their heart, I'm done. I'm one. Check, done. Well, there was a book years ago called If Disney Ran Your Hospital. I don't know if y'all have ever read that. When I was a CF, Sean, he was my first boss, Sean Schwarting, because that's a tongue twister. We called him Boss Man for short. He was the rehab manager. He had the entire team, interprofessional team, OT, PT, speech. Well, I was the only speech. But we read If Disney Ran Your Hospital. And he talked about how it boils down to not necessarily customer service, but compassion. And your therapy might not be great in that moment, but do they feel, felt, found? To paraphrase from my girlfriend, Chantel, do they feel secure? Does that caregiver feel equipped or empowered to try? Do they feel loved, like they're in that space where they can learn? That makes me think of our students. Do they feel confident to make those mistakes like you were talking about, Kelly, because they're going to make them. But if we're giving them this tool that y'all are talking about, then I feel like if Disney ran to the university, like you've given them the tool to have a safe space to make that mistake and learn. Okay, so then next question, because I promise this is connected in my head, the interprofessional practice. How do you teach that? And is that predicated on, do you have good stakeholder and buy-in in your community? Because there's some great pediatricians in my neck of the woods, and some I would love nothing more than for them to retire. So, yeah.
Kelly, do you want me to take it or do you want to jump in?
It does not matter. I just wanted to clarify the question. How do we teach students to practice with other professionals, or
all of the above? I'm like, you're in, like you started in the private practice, so you know the good doctors, like like if you go this way, they're going to make the referrals. But like that's.
Let me say this. I think one of the problems with our current arrangement, typical arrangement. Now, I can't speak for all programs across the country, but if since we have to be accredited, we have to be accountable that we're covering the 9 service delivery areas.
Yeah.
So that kind of sets you up for creating a program. And because larger institutions, people's jobs are predicated on them getting grant funding to maintain their positions, right? So I mean, those are realities. So you create this curriculum that is not person-centered, but rather disorder-centered. I have an aphasia class. I have a language class. I have a pediatric feeding resource class. But just like you and your listeners know, the pediatric feeding babies, sometimes it's the feeding that actually got us to recognize the 20 other things that are at issue here.
Yes.
And I think for me, interprofessional practices would become more natural, or our students would be more tuned into it if we were less disorder focused and more person-centered focus.
Yeah.
Like, let's look at babies. We get these babies with neurodevelopmental disorders. What's our mind map? Our mind map is a pediatric feeding disorder. Our mind map is an autism. Our mind map is a cerebral palsy. Our mind map is a motor speech disorder, right?
Yeah.
Doesn't it kind of flip how you would be learning it instead of staying so in your lane about, I'm just going to talk about motor speech this semester. I'm just going to talk about pediatric feeding this semester. But if we could flip it in such a way that the curriculum was representative of, we are treating the whole person, then to me, the fact, if I'm treating the whole person, I'm definitely going to have to talk to my doctors. I'm going to have to talk to maybe 3 different types of doctors, a rehabilitation specialist, a GI doctor, an ENT, all of those because someone has a brain injury. Who knows? Mm-hmm. So, I mean, I think that kind of falls more naturally if we look at the bigger picture versus so focused on etiology characteristics of each of these disorders. That's kind of where I would start. But of course, I'm the program director on the show today.
Okay. You said something. There was a poster session at ASHA this year. It was called The Relationship Between Infant Reflexes, Maternal Responsiveness with Feeding Skill Development. It was to be Dr. Sue, because she's getting her PhD, under Nina Capone Singleton out of Seton Hall. And that was the premise of her poster, was that she was going through and looking at reflexes in these infants and saying, when you actually look at these reflexes, they come in for feeding, just like you said. But when you're looking at even their reflexes, it's going to trigger the referrals. And then, oh, by the way, some of these reflexes, and Courtney, you're a CLC. When I renewed my CLC, they were talking about how if they haven't integrated AT and R, and I can't remember if it's this way or this way, then that is intimately tied in with dyslexia later on. But we're seeing it here. And so, yes, so cool.
Yeah. I love how Kelly talks about, it's so person-centered. And a lot of times it's very hard to teach all of these complex topics and keep it person-centered and remind that we're circling back to, but we want to treat the whole child, and we want to make sure that we are looking at all of the different aspects. I feel like, especially with PFD, it does not happen on an island, right? It's not just pediatric feeding disorders. So we have to teach them, everything about a PFD, but also how to take that next step of looking at the whole child. I am a really big believer in empowering parents. So, I teach the red flags of, here we need to look for red flags for referral to GI, referral to OT, referral to PT. We need to have these in the back of our mind. But we also have to make sure we're communicating and empowering the parents so that we accurately can describe it to them. So when we're following up with their providers or when they are at those appointments, they understand how to communicate what we're telling them and why. Yes. So I think that, of course, you're going to have your providers that are more receptive to our input. But at the end of the day, you have to have a parent that has the buy-in and has that understanding. We have to do a good job of explaining it so the parent understands as well. So that's just another thing that we really try to focus on, at least in my course.
And I think, Courtney, if we go back to that first reiteration of the article, we spent a lot of time describing the working relationship Courtney had with her partner OT. And I think I drove them crazy because for writing, we have to write with specificity to get published. And, if you're working well as a member of a team, it's very much like a dance. It's not a your turn, my turn, you're in. It's more who's doing what at what point in time, because you know each other and you fundamentally trust that your partner's going to get that information. And so I would drive them crazy because I'd be like, okay, so we're trying to tell readers, we're trying to teach readers how to be a team player. So I need you to help me understand, how did you know you were going to take the case study and the OT was going to do the body work first? Like, it was those kinds of things that I think are really hard to teach interprofessionally. And I would say that perhaps then before you try and teach specific interprofessional skills, start with that team aspect of you have to trust your teammate, because that's really what we spent a lot of time coming back to, is that Courtney and her partner, Allison, just were in sync with each other, that they respected each other's level of expertise that they brought to the table. And through experience and open communication, they learned how to do these evaluations in such a way to benefit the child. So there was no way to standardize it and say, we're going to start with the OT today and do blah, blah, blah. They truly were tuned into what did that infant or that parent need at that point in time. So I think the number one thing, if I was in Courtney's shoes at a private practice or doing home health or something, and I had a student and we were going to be doing some of these pediatric feeding cases, I think I would say your first goal is to identify some of the communication behaviors, verbal and nonverbal, that go into a successful teamwork for or during an assessment, because you don't have time, or you don't have time to kind of talk and hash it out in the middle, right? Because with your babies, you got a limited period of time that you're going to get what you need to get from them. So you've got to have a pre-plan, and then you've got to trust that your partner's going to carry out their part and lift you up while you do yours, and know how to communicate with you. Hey, could I jump in here or not? It's not something you could standardize. So I think teaching a student to have observational skills of what makes a really good team successful. Yes. Courtney, what do you think, back from our remember those early conversations when I was trying to get you guys to commit to something? How do you make this work as a successful team?
Yes. Yeah. To give you a little background on who Allison is. So when we first started the infant feeding program, it was kind of this idea that I just had, that I was like, I know that I just had come back from maternity leave from having my first. I was like, there's such a lack of access to services for breastfeeding moms. There are so many challenges. So I went to the two owners of the clinic that I work at, and I said, I have this idea, I want to try to find a way to service this population. I know that there's a need for it. I see all the posts on the mom pages. There's not an access to this service. A lot of times insurance doesn't always cover it, but I know a lot of times, they'll cover feeding. So I was like, I want to do this. I don't know how it's going to work, but here's my idea. And they were like, okay, go for it. Tell us what you need. And which is wonderful. But also then I'm like, okay, I don't know what I need. And Allison came to me when they, were talking about it at one of their meetings, and she was like, I love this. This is something I'm so passionate about. I want to do it with you. And so I was kind of like, I don't know how this is going to work, but let's figure it out. So from the start, we really developed it from the ground up. And I think that was a huge part of our communication. Is we were taking so many classes because we were like, we want to be prepared to see these kids. We want to make sure that we're doing right by the families. And through that, because we've had so much overlap in just our learning and the development, we were able to kind of identify of, hey, like, this is when I need to jump in. This is when it's a more OT. This is when it's more pressing, and really finding, how to best service the child and the mother to make sure that they are supportive. But there's so much we almost got to the point where we wouldn't even have to say anything. We could just look at each other and we would know, who was going to do what. But I was very, very lucky that she jumped in, because at the time, it was just a concept, and she's one of the reasons that it came into what it was and that it is so successful. But yeah, the communication aspect, I'd just say working really closely together and having that respect for your counterpart, of knowing that they are going to jump in with what their role is, knowing that when you spend that much time together, that they can identify the importance of your role as well. That's a huge piece of it. It's just having that mutual respect too.
Yes. And giving each other grace when you're learning to read each other, because that's there's also that storming, forming, norming pattern for like team building. And
Yes.
and when there's a new team member, it's always kind of it's like a boat on choppy waters. There's your storming, and then there's forming, and then it's norming, and you've normalized, and that's it. And I've seen that sometimes you pull a student into an established team, and even that one variable can rock your boat, storming, forming, norming. But this is amazing. Okay, one, I have to be respectful of our time, so I'm going to have to segue us over. But what are your final thoughts? What if a future clinical supervisor or a current clinical supervisor is listening, or if a student is listening, what do you want them to walk away with?
I was just going to say, find a really good support system. And especially if you're interested in pediatric feeding, find a really good supervisor that is going to spend that time with you to give you the support that you need. I feel like even when I first started out as a clinician, it took a good 1 to 2 years before I even felt like I had a very good handle on just managing my cases. It is such a learning process, and you never stop learning. I'm still learning so much. I learned so much from Kelly, and she's been such a big instrumental part in me developing into the teacher and supervisor that I am. But you have to find your people that believe in you and that will really give you the time and effort to put in to make sure that you have all of those supports. But
Yes. I agree with Courtney. I think that all of us, I think you just have to have a willingness to learn. And as you said, to be humble about, oops, this was kind of crazy. And I think for our new clinical supervisors that are just either getting into the game to supervise at their workplace, our students, or if you're hired as an adjunct somewhere, we wouldn't hire you if you didn't have the content expertise. So bring that confidence with you. I mean, I'm not challenging you ever on your content expertise. You wouldn't be in my classroom if that was the case. But more so, be just like the students you're teaching, and say to your colleagues, hey, can I get some help on this? What do you think is a really good way to do this? Just like we want them to approach the clinical decision making, I think our supervisors should. We know you know what you're doing. We know you've got your job done. You're great, and we are so grateful you're supervising our students. We want to help you, and I feel sometimes our offsite supervisors and adjuncts sometimes feel like they have to somehow meet some standard because they don't work for the university like the full-time university staff, that they're not willing to call us and say, I really could use a little help with this student, or real help with teaching this. And that's, we're there to help our students. And if you let us help you, then you're helping our students. So talk about some interprofessional teaming. I mean, I think that's truly what I would say. And again, I always say this to my supervisors, your students are there because they want to learn. They want to be as good as you. Just chunk it up for them. Break it down. Tell them what you want them to learn. Check, see if they learned it. If they didn't learn it, go back and let's reteach it. Ask them how they could best learn it. Like, be a collaborative partnership in the learning process. And again, I know they got to get a bazillion hours, but they don't have to do everything right away. They can just do some reflective, some watching. I think one of the most underutilized tools in clinical teaching is modeling.
Yeah.
My supervisors at my clinic, our university clinic, I'm always like, if you're not in those babies the first 4 weeks, like, you're not running those sessions. How do they know what good stuff looks like? So, feel free to show off, but just make sure you're going back and say, what I was showing off was specifics. No.
I worked at a university where the other clinical educators day one were not in the sessions. And I was like, oh my goodness, these speech babies came in with a degree in not speech, and we still have to chart progress and growth. Like, get in there. And the storming that I caused by being in there. And then I'm one of those, I'm going to ask forgiveness instead of permission, because especially for pediatric feeding, I mean, if you mess this up, I mean, bad news bears could happen, right?
Yes.
And so, I mean, I go down the rabbit hole of like penetration aspiration. We could, have a choking incident. We could have a trauma, like But love that you said that. Oh, this is lovely.
It was a good storm you caused, I would say. A necessary storm.
Yes, ma'am. I'm sure it did not necessarily win me friends, but you know what? The hill that I will die on. There's a few of them.
As a side note, I always, with my team, I have a great team where I'm working at Austin Peay. My colleagues are the best team, all of them, my adjuncts and my full-time faculty. And I have learned that I'll do this. I'll say, hey, I've got this really great idea. We just think about speech-language pathology underwater, swimming backwards, upside down. And I just have to toss the idea out and let them all do their, what you just saying? And I'm going to tie it back to learning, because I know I toss these crazy ideas out, but I know they have to sit on them and think about it.
Yep.
Then, just like we talked about with mind maps, and they're all going to come back to me the next meeting, and everybody has to say it their way. They have to say what their objections are. They have to say what they think is good about the idea. And then now we all have, right? We all have our experience on this. So now let's really talk about this idea and how can we bring it to fruition? Because now we can immerse ourselves in the experience, because we got the emotional piece. I let that emotional piece be exactly what it needs to be. Your way to process this. And I think that works for us both ways, both as adult learners and for our students who are adult learners as well.
Yes. But that's a hallmark of good leadership. Let them have a moment, give them time to process. So kudos to you. Because that, and mom is the word. On that note, folks, when we're talking about good mentors, I just want to give you a reminder. The same is to be said for caregivers. So while we're filling their cup, figuratively and maybe literally, they may need more. So I'm going to push us back over to Feeding Matters and remind everybody of the Power of Two program, where caregivers can call in and for free get a caregiver mentor to have somebody to bounce ideas off with. And what I have found is caregivers will share with me, but I'm still a figure of authority. I am still a professional. And they may not want to share the big, bad, scary, ugly, because they need another caregiver to go there with, which I get, right? Like, the person in your village that you're going to call to troubleshoot an idea because you anticipate the answer, right? Same to be said. So just remember that in the grand scheme of things, are we making sure those caregivers have a mentor of their own while we're mentoring future generations and getting mentored by our interprofessional practice partners and those that have come before us? So just as to close the loop. But then last question for you ladies. If somebody wants to reach out to you because they have questions, how do they reach you? And then if anybody's got a little love money, where can they donate it to?
I can be reached by my email, kleinhansk@apsu.edu. And we do run a free university clinic for our first year students for training, a very robust clinic. So you could reach out to the Austin Peay State University Foundation and make a donation that would be directed to the APSU Speech, Language, and Swallowing Community Clinic. And we'd be very grateful for that. Thank you.
Thank you. Courtney?
I will second with Kelly's donation. I'd say anything that Austin Peay doing, they're doing amazing things, getting their clinic all set up. I'm very excited for the swallowing side of that to eventually be set up and ready to go. And also Feeding Matters. They do such wonderful work. I always reference them as a resource in my course, make sure students know that they can use them and access them for different articles. But they're such a great resource. So that would be, if you're going to donate money, one of those two places. And if you would like to reach me, you can reach me through my email. It's CourtneyRRichards@gmail.com.
Beautiful. Folks, you know where to find me. I'm on Instagram. I'm on Facebook. Will I answer your messages in a timely manner? No, but even my son was laughing. Could you hear Goose laughing? Oh, bloody hell, Goose, you're ratting me out. But I will get to it. So reach out. And then when I hyper-focus on responding, I will respond to all of the things. But ladies, thank you so much for coming over. Goose, thank you for interjecting at comedic times.
Remember to visit speechtherapypd.com to earn 0.1 ASHA CEUs for this episode and to see our library of over 1,400 courses for all things SLP.